So we are alive at a moment of a once-in-a-century event. But we are not the first generation of human beings to face this ancient threat. And while we have come to live right now in a way that's very alien and unnatural, what I'd like to emphasize is that plagues are not new to our species. They're just new to us. We think this is so crazy that we are being called upon to live in this fashion. And yet that is not true. For thousands of years, people have been confronting outrageous epidemics like the one we are confronting right now. And just a moment's reflection should make you realize this. Plagues are in the Bible. They're in Homer's Iliad, which is where Apollo's arrow comes from. They're in Shakespeare. They're in Don Quixote by Cervantes. Plagues are a feature, are a part of the human experience.
Tonight, we will talk about the book Apollo's Arrow with author Nicholas Christakis. I'm Mary Eintema, the president of World Boston. Dr. Christakis, MD, PhD, MPH, is a social scientist and physician at Yale who conducts research into the fields of network science, biosocial science, and behavior genetics. He directs the Human Nature Lab and is the co-director of the Yale Institute for Network Science, where he is also the Sterling Professor of Social and Natural Science. His lab focuses on how health and health behavior in one person can influence a person's social network. The lab also examines the spread of altruism, emotions, and health behaviors along network connections. So, Dr. Christakis, welcome to World Boston.
Thank you so much for having me. Thank you, Mary, for that introduction. And thank you all for your interest in this topic. I thought I would just spend a little bit of time doing some basic epidemiology initially, and then talking a little bit about the ramifications of the pandemic, including actually specifically discussing the ways in which the pandemic may be intersecting with some of the political developments that we're seeing right now in our society. So we happen to be alive, all of us listening, at a very unusual moment in the life of our species. We're alive at a time when a new pathogen has been introduced into our midst. And this pathogen, SARS-CoV-2, will circulate among us now forever. And actually, this pathogen is having what is known in ecology and evolutionary biology as an ecological release. You can think of the pathogen as an invasive species, just like if you released rats on some faraway island and they ran over the place because they had no natural predators and all these new opportunities for them to predate and eat other things. That's what we are like to the virus. The virus has been introduced among us. We have no natural immunity to this virus, none to speak of. And the virus is now going to just spread and spread and spread limitlessly, basically, among the human population. And by now, even actually from early on, we knew quite a bit about this virus. Chinese scientists were publishing useful information, useful epidemiological parameters about this virus right from the beginning in January. But by now, a number of the intrinsic epidemiological properties of the virus are well understood and well known. One of them is the intrinsic lethality of the virus. How bad is this virus? How deadly is it? This can be quantified in a number of ways, but one of the most basic ways is something known as the infection fatality rate. What fraction of people infected with this virus will die? And that number is between 0.5 and 0.8% of people who are infected with the virus will die. If you get symptoms of the virus, if you have a symptomatic infection, then we compute something different called the case fatality rate, and that's approximately double the number I just gave you. So if you have symptomatic COVID, even mild symptoms, on average, your probability of death is between 1 and 1.6%. Now, that's actually not a benign, not a trivial percentage. From a public health point of view, that's quite a serious virus. It's at least 10 times deadlier than the flu. On the other hand, we should count ourselves lucky that the virus isn't as deadly, for instance, as the bubonic plague, which might kill 50% of the people that it infected, or smallpox, or cholera. And I want to highlight for the audience the following idea, which is that there's no specific reason this virus isn't deadlier. There's no God-given reason we're not facing right now in the 21st century a pandemic similar to the bubonic plague, or similar to, for the sake of argument, the fictional pandemic that afflicted people in the movie Contagion, where perhaps 1 in 3 people died of that disease. So the lethality of the pathogen is an intrinsic property of the pathogen. And this particular pathogen kills approximately 1% of the people who get symptoms from it. Another important property of the pathogen is how transmissible is it? How infectious is it? This property is quantified by a number that most people know by now, the so-called R naught, the R sub zero. This is the basic reproduction number of the pathogen. It's a property that's intrinsic to the pathogen and has to do with how easily it spreads from person to person. Very quickly, we learned that this pathogen was actually moderately infectious, actually more than moderately. For each initial case of the disease, of infected person, between 2.5 and 3.5 other people would subsequently become infected. Let's say about 3. And actually, this is significantly more infectious than the flu. Influenza has an R naught of about 1.5 for each case. It barely reproduces itself. It makes one new case plus half another case, 1.5 new cases. Very infectious diseases, for example, like measles, might create 18 new cases. Measles is probably the most infectious disease known, spreads very, very easily. And again, this is an intrinsic property of the pathogen at the very beginning of an epidemic, when there are no immune people, the hosts have not acquired natural immunity, nor has the host yet changed its behavior. When you want to quantify how fast the pathogen reproduces itself after the host has begun to respond, you use a slightly different number, the so-called RE, the effective reproduction number. And that's what we're trying to drive down by engaging in physical distancing and all the other things that we are doing. Now, if you took these two simple numbers that I've just introduced and you plotted them on an XY curve with how deadly the pathogen is, let's say, on the x-axis, and how transmissible it is on the y-axis, and you looked at all the respiratory pandemics for the last 100 years, for example, going all the way back to the 1918 Spanish flu, the last most serious pandemic we've had, and you plotted them on this curve, on this graph, here in the upper right, you would see the 1918 pandemic, the most deadly and the most transmissible. Down towards the bottom, you might see the 2009 influenza pandemic. Many of you probably don't remember that pandemic. Why? Because even though it was a pandemic, it wasn't very deadly. People just got a common cold. It wasn't serious. So it happened, but it was down low over here. The previous second worst pandemic we had was in 1957. 110,000 Americans died. That'd be about 220,000 Americans right now, given the population changed. And so COVID-19 is now the second most serious respiratory pandemic we've had in the last 100 years. So we are alive at a moment of a once in a century event. But we are not the first generation of human beings to face this ancient threat. And while we have come to live right now in a way that's very alien and unnatural, what I'd like to emphasize is that plagues are not new to our species. They're just new to us. We think this is so crazy that we're being called upon to live in this fashion. And yet that is not true. For thousands of years, people have been confronting outrageous epidemics like the one we are confronting right now. And just a moment's reflection should make you realize this. Plagues are in the Bible. They're in Homer's Iliad, which is where Apollo's arrow comes from. They're in Shakespeare. They're in Don Quixote by Cervantes. Plagues are a feature, are a part of the human experience. And so we, right now, in the 21st century, there's no particular reason we should be spared this ancient threat. And one of the ironies is that actually we have only at our disposal ancient tools to respond to this ancient threat. In a bit, I'll come back to the issue of the vaccines that we've invented and some of the medicines that we have. The invention that we have achieved of this vaccine is miraculous. It's honestly miraculous. But I want to highlight that we are the first generation of human beings ever alive who, while facing an epidemic of this type, has been able in real time to invent a specific countermeasure, a pharmaceutical countermeasure like we have. So we actually primarily had at our disposal the so-called non-pharmaceutical interventions, the different kinds of things we could do that did not involve modern technology and that had been available for thousands of years, often appreciated by our ancestors to try to protect ourselves from the pathogen. And all of you know what these things are, of course: wearing masks, washing your hands, closing schools and businesses, banning gatherings, testing, quarantine, which has been around for several hundred years, and other kinds of interventions that we might implement. But the right way to think about these interventions is that no specific intervention is is perfect, but each intervention can achieve something. And there is something known as the Swiss cheese model of how we cope with pandemics. Imagine that each intervention is a layer of Swiss cheese, each of which has holes in it, so it's imperfect. In other words, and imagine how we're stacking up layers of Swiss cheese, a virus trying to get through the layer of Swiss cheese, if it happens to fall upon a hole, can get through the layer. So one layer might be testing, for example. Another layer might be masking. Another layer might be hand washing. Another layer might be a school closure. Another layer might be, a gathering ban, and so on. But each of these layers, while imperfect, the holes are in different locations. And so if you stack up 3 or 4 slices of Swiss cheese, by the 3rd or 4th slice, you have a perfect barrier. So the virus can no longer penetrate. That's what we're trying to do. We're trying to add on layers of protection against the spread of the virus. Even the vaccine can be thought of as a kind of layer of Swiss cheese, which is not perfect. Most of you are probably aware that the Pfizer and the Moderna vaccine have 95% effectiveness, but they're not 100% effective. And so even when the vaccines are widely adopted, for some time after that, many people will still choose to wear masks or engage in other self-protective activities. Now, I think one of the things that's very important to understand about the predicament we are in is that many people might think, oh, we've invented a vaccine. Actually, before I get to that, I want to back up and say something else, which is that many people might be under the misimpression that the way our economy has collapsed relates in some part to state actions, that the government is ordering businesses closed or enforcing lockdowns. But I think it's very important to realize that economies have been collapsing for thousands of years during times of plague, and the governments weren't ordering businesses to close or schools to close. The main driver of the economic collapse is the virus. It's the virus that's doing this to us. And any actions that the state has taken, typically, if anything, have reduced both the epidemiological impact of the virus and, I would argue, the socioeconomic impact. Now, one of the things that's also very important to realize about times of plague is that it's not just a biological phenomenon, germs spreading through social networks. Plagues have for thousands of years, been characterized by certain psychosocial phenomena. For example, the desire to blame others. Many people find it very soothing, ironically, when there is such a catastrophe afflicting them, to imagine that it is a product of human agency, that we can blame some other person, and that we can blame, for example, during the bubonic plague, the anti-Semitism rose and they wanted to blame the Jews. Or during the epidemics of syphilis after the discovery of the New World, the French called it the Spanish pox, and the Spaniards called syphilis the French pox, for example. Or during the HIV epidemic, there was a desire to blame homosexuals or IV drug users or Haitians, for example. This desire to blame others is extremely typical. And one of the motivations for this is often that people would rather imagine that there is a play of human agency, that some people are responsible, rather than to imagine the alternatives, which are often more frightening, like that plagues might be the workings of an implacable God, or the inexorable workings of the natural order. So blame is a common feature of plagues, and we are seeing that happen again in our society today. Misinformation is another common feature of plagues. And denial, misinformation, lies and denial. Many people think of plague as one of the 4 horsemen of the apocalypse, and I would argue that right behind the horseman is his squire, which is mendacity. The germ follows social networks, spreads from person to person, and right behind it spread lies and denial. This has been seen for thousands of years, and yet again, we're seeing it in our society today. Unfortunately, including even the president of the United States, who for months spread frank misinformation that the plague was not more, that the virus, that COVID-19 was not more serious than the flu, that hydroxychloroquine was an effective response, and so forth and so on. But the point is, it's not just our leaders who often, alas, but not always, lie to us. People themselves don't want to believe these bad things are happening. People themselves would rather believe that the plague can be wished away, that we can just deny it. And many other psychosocial features as well are parts of these types of epidemics. One of the things that happens during epidemics like this is, and this now intersects with some of the political things that we've been seeing in our society. If you look across time, serious epidemics often coincide, believe it or not, with periods of climate change. Even going back to Roman times, we have records of this, and certainly during the bubonic plague attacks in medieval times in Europe. And also they coincide with political instability. Now, on the one hand, it's not hard to imagine how, for example, warfare might pave the way. Political instability and warfare might pave the way for epidemics. For example, in the 1918 pandemic, the existence of World War I and the troop movements and the hardships and the starvation and all of the other stuff associated with that war paved the way for rapid spread of the pathogen. But it also works a little bit the other way around, because during times of plague, people search for meaning. There's a search for meaning. When people are afraid, when they're scared about what's happening, when they're stuck at home and don't have other occupations to occupy their minds or their time, people begin to think about the meaning of their lives. This is very typical of times of plague. For example, during times of plague, religiosity rises. And we're seeing that in the United States right now, a rise in religiosity. And there were other features that we've seen in the last few months in our society. For example, over the summer, after George Floyd was murdered, there were all these protests, these Black Lives Matter protests. And it's true that part of those protests had to do with the fact that people were out of work. First, there's a long history of police brutality, but in addition to that, people were out of work. People had been isolated in their homes. There was a kind of pent-up desire for social interaction. And all of those factors were driving, of course, the protest. But an additional factor was the fact, I believe, that people were reflecting on the meaning of life and the meaning of their own lives, and that the protest provided them an outlet for that search for meaning. We see this search for meaning as well in healthcare providers. For example, during times of plague, physicians and nurses have a higher calling. Certainly, I experienced this myself during the early part of my medical practice. I was a hospice doctor for many years, but my early career coincided with the HIV epidemic. And young people were being killed by this epidemic, and we had to care for them, sometimes at risk to our own lives, much lower than the SARS virus is imposing on healthcare workers, where thousands of healthcare workers have died. But nevertheless, it prompts doctors and nurses to think about their duty, about the worth of the work that they are doing. And there's a kind of heightened sense of meaning in the professions, the health professions, during a time of plague. Incidentally, even the death of healthcare workers is not new. Thucydides in the Plague of Athens in 430 BC talks about how all the doctors were dying. Pope Clement VI, in the first attack of the bubonic plague in 1347, similarly noticed how all of the sisters, the nuns that were caring for the sick, they were afflicted and dying as well. So even the death of healthcare workers that we're seeing now, and the lonely deaths, the fact that people are dying alone, something I never imagined we would see in the 21st century in our rich, ostensibly well-prepared country, have also returned, as they have afflicted human beings during times of plague for a very long time. So finally, this search for meaning, I think, is even manifesting itself right now with the right-wing protests. It's not just left-wing people who are searching for meaning, right-wing people are searching for meaning as well. And I think it's against the background of things that have been happening. This is not the only explanation, but I believe that this kind of fulsome sense of framing what they are doing as patriotic, as a kind of patriotism, I think also intersects with the ways in which plagues heighten a search for meaning. Let me talk briefly, and then I think I will stop after this rat-a-tat-tat description of some basic ideas, some basic history of epidemics, some basic epidemiology. We can talk more if you want about the vaccines, because I don't actually think the vaccines are going to, well, they're miraculous, but I don't think they're going to make a very radical change in the time course of the epidemic. And I'll explain that in just a moment, because I believe that we are not at the beginning of the end of this epidemic. We are still only just at the end of the beginning, actually. We are just still in the opening act of what this virus is going to do to us. Let me explain a little bit how I'm thinking about this, and then I'll I'll shut up and we can do some questions. So the vaccine has been invented roughly as I had imagined it would be, given the number of different interventions, given what we know about veterinary coronaviruses, given what we know about the biology of coronavirus. It's not wholly unexpected that a new vaccine would have been available and invented by the first quarter of 2021, even though it is miraculous. We are the first generation of human beings whose time in the crucible coincided with the ability to actually do something material about it using pharmaceuticals. But we still need to manufacture millions of doses of this vaccine and distribute these doses competently. And most importantly, persuade Americans to accept these doses and get vaccinated. And we need to get to a point known as herd immunity by doing this. Let me sidetrack for a moment, talk about herd immunity, and then I'll return to what's going to be happening over the coming years, and then I'll stop. Herd immunity is the idea that a population of people can be immune to a pathogen, even if not every individual within it is immune. For example, consider the idea of measles. 96%, imagine that 96% of the people have been vaccinated against measles, and one of the 4% who hasn't been vaccinated somehow contracts the disease. Well, that person can't spread it to anyone or cause an outbreak because they are surrounded by people who are immunized against the pathogen. So even though not 100% of people are are vaccinated, even though let's say only 96% are vaccinated, we don't get epidemics of measles. That threshold, that percentage is the so-called herd immunity threshold. And that percentage varies according to how infectious the disease is. The more infectious the disease, the larger the fraction of people you need to immunize. The less infectious the disease, the smaller the fraction. This is why for relatively not so infectious diseases like influenza, we can get away with vaccinating, let's say 30% of Americans. And that's enough to tamp down on the influenza outbreaks. Now, the formula for this is you take the R naught that I talked about at the beginning, and you compute R naught minus 1 divided by R naught. So in the case of SARS-CoV-2, the R naught is, let's say, 3. 3 minus 1 is 2. 2 divided by 3 is 67%, according to this naive calculation, would have to be immunized. Incidentally, this new variant that has emerged that's more infectious, but so far as we can tell, thankfully not more lethal, it has an R naught, let's say, closer to 4. So if you do the calculation, 4 minus 1 divided by 4 means 75% of people would need to be immunized before we reach this threshold of herd immunity. And furthermore, I need to be clear because Tony Fauci has been a little bit, he knows the difference, but in his public remarks, he's been conflating a couple of issues. We actually ideally want to vaccinate a number that surpasses that to really get protection. Because even if you reach herd immunity, all it means is that you have stopped the epidemic force of the pathogen. You've taken the wind out of its sails, but you haven't eradicated the disease. The pathogen is still there. It can still infect people. It can still spread and cause trouble. Nevertheless, this is an important milestone. But actually, these numbers that I just told you, for example, 67%, need to be revised downward given a technical issue having to do with network science, which is what my laboratory studies. That not everyone is equally likely to spread the disease, basically. So you take 67% down, probably closer to 50%. The point is that we need to vaccinate at least 50% of the people. And between manufacturing the vaccine, distributing it, and getting it into 50% of people's arms will take about a year, I would estimate, plus or minus. So that's quite a long time still, incidentally. And at the rate we're currently vaccinating people, it would take 5 years because we're doing such a lousy job of handling the vaccine rollout. Meanwhile, the virus is still spreading. Right now, probably 14% of Americans have so far been infected. And we need to get to at least 50% infected naturally before we reach herd immunity naturally. So from my perspective, we're going to be living in this initial period. The initial epidemic period will last through early 2022, when the virus has just come into our species and is wreaking havoc. And then by then we will either reach herd immunity artificially because of vaccination or naturally because of the natural spread of the virus. And at that point, we will have put the epidemiological and biological impact of the virus behind us. but we're still going to have to deal with the psychological, social, and economic impact of the virus. Let's not forget 30 million Americans are out of work. Millions of businesses have been closed. Millions of children have lost school. Millions of Americans will be disabled even if they've not been killed by the virus. By the time this pandemic is over, between 500,000 and 1 million Americans will have died. This is mind-bogglingly bad. Our nation has collapsed, in my view, in the way that it has confronted this virus. So between 500,000 and 1 million Americans will die, and we don't know for sure right now, but probably 5 times as many of them will have some kind of long-term disability. I'm not talking about long COVID or short COVID, which is the duration of your symptoms when you're first infected. I'm talking about after you recover, what fraction of people will have pulmonary fibrosis or renal insufficiency or neurological or cardiac problems of long duration. They'll be disabled in some way. So 5 times as many as die will be disabled. So at least 2.5 million Americans will have some kind of disability. Just as a benchmark, only 750,000 of Americans in total have end-stage renal disease. So that's another thing we're going to have to cope with. The very large number of disabled Americans that are making demands and claims upon our healthcare system. So if you look at the history of pandemics, it typically takes a couple of years before people can begin to recover from the social and economic and psychological shock, now also the clinical shock I just mentioned, of the disease. So that intermediate period will last, let's say, until 2024, approximately, plus or minus. And these things aren't bright lines, there'll be smooth transitions between them. And then, roughly then, I think we will enter the post-pandemic period of the disease. And here I think we will now begin to see a kind of roaring 20s of the 21st century, similar to the roaring 20s of the 19th century after the 1918 pandemic. Remember earlier I told you that religiosity rises during times of plague. Because there are no atheists in foxholes. Well, now at the end of the plague, actually religiosity will decline again, which is what's seen typically. Remember now we discussed how people are withdrawing from social interactions, but after having been cooped up for a number of years, that trend will reverse as well. People will relentlessly seek out opportunities for social interactions in nightclubs and restaurants and sporting events and musical concerts and political rallies. I think that we might see some sexual licentiousness. People will have, been very frustrated from not having opportunities to interact socially with others for a number of years. All of the economic collapse that we talked about earlier, which happens even absent any government interaction, where people are sort of having, have been saving their money, they've been abstemious, now will reverse. People will start spending their money. They'll take risks. The risk aversion of the epidemic period will reverse. We'll see a kind of entrepreneurial spirit, a kind of efflorescence of the arts. I think not dissimilar than the Jazz Age kind of thing that was seen 100 years ago. So I think the post-pandemic period will have many of these features in the initial part, and there will be some persistent long-term changes in our society introduced by this rather serious disease that we are facing. Thank you.
I have to unmute myself. Thank you very much, Nicholas, for very thought-provoking remarks. I can't help but, so I have to admit, looking through your book, what I went to first was, how does this end? How do we get out of this? And I guess in some ways the picture that you paint is not so rosy. It's not just like the vaccine and we're done.
No, and remember, before the ability to invent and distribute vaccines, plagues always end. I mean, they end. But the usual thing that happened is also, I didn't discuss in my remarks, has to do with the ways in which the pathogen and we reach a modus vivendi, where the pathogen over long periods of time evolves to be less deadly, actually. And I think the ultimate end of this pathogen is that it'll be a little bit like there are 4 coronaviruses in our species that cause the common cold. I think in 100 years or sooner, this pathogen, SARS-CoV-2, will be like that. It'll circulate among us. It'll infect us when we're young, not kill us. We'll develop some immunity, and eventually we'll have this type of, and the virus will evolve to be more benign.
Okay. So I guess question is, why? I mean, you've shown us so many historical parallels from, blaming others to misinformation, climate change, instability, et cetera. Why are we so bad at responding?
I mean, on an individual level, there are very few human beings alive that have faced this type of epidemic. Of course, in isolated parts of the world where there are cholera outbreaks or Ebola outbreaks, people have a healthy respect for diseases, but there are few Americans who've had this experience personally. I honestly don't understand why we've done so badly. We're a rich country. We have many strengths. We have open expression. We have world-leading scientists. We had plans for pandemic preparedness. Some people say, I mean, I think a lot of the blame, frankly, lies at the White House, which I think has not been competent in leading the pandemic response. And some people say, well, other countries did poorly as well. For example, Italy and the United Kingdom.
Right.
But I'm not jingoistic, but I'm sufficiently proud of our country that I was like, well, we're the United States of America. I had higher expectations of what we would be able to do to effectively respond to this. It was known what we needed to do. We should have been, I didn't talk about this in my remarks, but I began doing research on this pandemic in January, where in collaboration with some Chinese scientists, we were tracking the movement of people, millions of people through Wuhan, and tracing how their movements forecast the intensity of the epidemic and the timing of the epidemic in other parts of China. And by the end of January, it was very clear to me and many other expert epidemiologists that I was in conversation with at the time that this was going to be a serious pandemic. And yet when I looked at the public discourse about this, the public didn't seem to be alarmed. And I was very alarmed. And I said, how is it possible that I have a better understanding of this than the president? This can't be. And now we know, of course, it's not the case. I mean, the president has the NSA and the CDC, and the president appropriately has access to vastly better information than I do, but didn't act on it. What we should have been doing, what happened in late January, and many of you know this by now, but just to be very clear, the Chinese, by January the 25th, were sufficiently alarmed by this virus that they promulgated regulations that required 930 million people to stay at home for months. They thought the virus was so bad that they basically detonated a social nuclear weapon to stop it. Mm-hmm. 1 billion people were under lockdown. So we should have paid attention when that happened. We should have been preparing the American public for what was going to happen, had consistent public health messaging, manufactured and distributed PPE, prepared our healthcare system and our ventilators. We should have been preparing testing to be much more competently and widely available. It was months. We still don't have enough easy testing in our society. We should have been preparing surveillance systems so that we could track the virus. We were flying blind. We're still flying blind. We don't know right now. We're not doing enough genetic surveillance to know where the new variant is, for example, and how prevalent it is. It's embarrassing that our country is doing so pathetically poorly in its response. So these are the things we should have been doing, and we knew to do. There's a book on my shelf right here that you can't see called A National Plan for Pandemic Preparedness. You could literally open the book and say, okay, this is what you're supposed to do. And we did not do those things, alas.
Okay, so you actually just touched on my next question, and we do have something from the audience, but if you could speak a little bit about this, the variant, the new strain. You were talking about how sometimes a vaccine will evolve to be less lethal, or I guess in this case, it's more communicable. What do we know, and how would that potentially change the course to how this ends?
Well, it's a complicated question. Here's what we know. On an individual level, this variant, actually, there's more than one similar variant that have appeared, and they're already around the world for sure. By the time we detect it, given how many people are infected, it's spreading everywhere. This variant is, if you get sick from this variant, your probability of death is unaffected compared to the old variant. So on an individual level, there's not much difference. But the variant is more communicable. It spreads more easily. And there are a number of mechanisms by which it does this. One mechanism might be that when it infects you, it creates a higher viral load. So you can spread it more easily because you have more virus in you. or it could bind more easily to the ACE2 receptors in your nose. So if I sneeze on you with the old variant, it might not latch on to your nose, but if I sneeze on you with a new variant, it latches on, it's more avid, for example. Or it might be more irritating, that makes you expectorate more, so you cough more and spread it more. Any one or several of these things might be the mechanism by which it achieves its greater communicability. But what this means is that what we need to do as a nation is get even more vigilant about our non-pharmaceutical interventions, reducing more masking, more physical distancing, more bans on gatherings, more of these things that we either as individuals you should do, because now there's a more communicable variant, or as a nation we need to reinforce, especially since the vaccine is on the horizon. So if we just behave well for a few months, we can get a better release from this. Now, it turns out that from the point of view of maximizing the chances of Darwinian evolution of variants that are worse for us, every action that we are taking is actually stupidly facilitating this. So as you get larger number of people infected, you provide a larger pool for the virus to, by chance, evolve a worse variant. So what we've done is we have this very large group of people now, and so it's not surprising that variants are emerging here, there, God knows where, that can actually cause us more trouble. And if we botch the vaccine rollout and do it slowly, it's like applying just a weak selection pressure on the virus, like almost creating the circumstances for the emergence of a strain that could evade the vaccine even. We have no evidence yet that there have been vaccine evading mutations. Actually, that's not exactly true. There's some hint that some variants of the virus, the vaccine is not quite as effective against them, but it seems that this is uncommon. So people are not so worried about it yet. But if we roll out the vaccine very slowly, then what we're doing is we're kind of letting variants of the virus that the vaccine doesn't stop become more common in our society. Really what we should be doing is what Israel is doing, which is as rapid as possible vaccination of the population.
Great. Okay, thank you. I do want to remind our attendees that the way we're taking questions is by the raise the hand function, not the chat. That said, I think we have Eve Sullivan ready to go with a question. Eve?
Thank you, Mary. Thank you, Dr. Christakis. What a tsunami of information. I took notes. Thank you.
Well, there's more in the book.
It's on my list. Yeah. Thank you. My question is two parts. You talk about the effect on individuals and our actions as individuals. I'd like to hear you speak about the role of families and parents on the receiving end. In other words, what is the effect of all of this on family life? And at the same time, what is the role of parents vis-a-vis their children, vis-a-vis their elders? I am one, in getting us through it.
Well, that's a broad question. I think I'll tackle it in two parts. The first thing I'll say is it is in the intrinsic nature of infectious disease that it's a collective threat, and therefore it requires a collective response. There are limits to what any one individual can do. They can take certain self-protective steps, of course, but it is a collective threat. It would be like if an army was invading us. You could take your gun and go to the frontier and try to stop the invading army. That's pointless, right? You'll be overrun. There's nothing an individual can do to stop an army. Or multiple citizens could, in a disorganized way, take their weapons and go to the frontier, but that's not effective either. They're not organized. They're not coordinating their responses. You need some kind of state action, state actors, or you need some kind of effort to have collective response, to organize, to cooperate, to beat back a threat of this kind. So the pathogen requires cooperativity and collective response. Now, in fact, that is what people are doing. The irony is we are banding together to spread out, right? We are working together to separate physically from each other. And that is, of course, essential. And of course, mask wearing and a lot of these other things interrupt chains of transmission. You wear a mask not only to protect yourself, but to protect others, right? It's a kind of altruistic act when you mask and take some of these steps. So part of my response has to do with it is appropriate to think of it as a whole family problem, right? Insofar as the family is interacting socially, everyone has to kind of work together. It's also important to realize that what happens that we have to work together. There's a kind of metaphor, it's a bit slightly off color, but having uncoordinated responses to the pandemic, having one member of the family act more laxly than another member, or one region of the country act more laxly than an adjoining region, it's a little bit like designating one part of the swimming pool for urination and hoping for the best. It doesn't work that way. You have to have the whole thing, has to have a kind of coordinated response strategy.
Okay, thank you. I will not be able to get rid of the swimming pool. John, unmute. Okay, hello, John.
Hi. Yeah, thank you so much for this talk, Dr. Christakis. So I'm particularly interested in the marked inequalities that we see in the U.S. COVID experience, and in terms of infection rates, case fatality rates, et cetera, along both socioeconomic lines and racial lines. Perhaps it's somewhat obvious, but I'm interested in your thoughts and take on what some of the drivers are.
Yeah, I mean, this is an old debate. Also, we're not the first ones to think about this, and the debate has been framed for hundreds of years in the following way: that the germ is an equal opportunity killer, right? That it just kills humans. The germ doesn't care whether you're rich or poor or black or white. It just kills us. And believe it or not, this exact observation has been made for hundreds of years. Philosophers and others, priests actually writing in the 6th century, have made this observation that if anything, we should therefore see our common humanity and bind together to confront the pathogen, that it might bring us together, the fact that there's this shared enemy in the form of the pathogen. Now, on the other hand, unfortunately, the pathogen is also called forth for a lot of hostility and the opposite, right? Every man for himself, kind of neglecting the commonweal, bodies in the streets, for example, during the bubonic plague, families abandoning each other, father abandoning son, mother abandoning daughter. There are lots of accounts going back hundreds of years how this also had happened. And in fact, when this pandemic struck, some people speculated that the pathogen might draw Americans closer together. It might highlight our shared vulnerability, and it would be seen as an equal opportunity killer. On the other hand, that's not true either, because actually pathogens tend to afflict, like any predator, tend to afflict weaker members of the species, whether the old, the aged, or the very young, the poor, the imprisoned, people who are disabled or chronically ill, or people who, for example, are in some kind of minority group that otherwise already has some kind of social challenges. And every one of those axes, in fact, is exactly as you alluded to, that the germ has preferentially attacked stereotypically vulnerable groups in our society. Now, it turns out specifically on the racial grounds, depending on the specific ethno-racial group you're talking about, and depending on how you approach the problem, whether you control for occupation or not, or control for age or not. For example, if you look at if on average, let's say blacks are more likely to be in the service industry and less able to work at home, after accounting for occupation, you might see actually it's not afflicting blacks more than whites. On the other hand, if on average blacks are younger than whites, even the same rate of infections in blacks and whites, actually you can see that after accounting for age, it's worse in blacks, right? So initially it was seen that Hispanics were not at greater risk than whites in our country, but Hispanics are younger than whites. So actually after accounting for age, it turns out they are at higher risk. So this is also a complicated topic to give you a specific answer on this regard. But I'm very much of the school, I won't say I'm not so interested in these differences, because I am, but I don't think that's the primary focus, in the sense that the real problem is that hundreds of thousands of Americans are going to die. And as a nation, we are not competently yet responding to the pandemic.
Hi, doctor. Thank you for taking my question. You said in the beginning of your presentation, you talked a little bit about the mortality rates, but obviously we've all read about how the mortality rate is so different based on your age. And how does that affect at all your thoughts about how we come out of this through 21, especially as the vaccines rolled out? For example, in my simple mind, I say, well, gee, if we could just vaccinate everyone over 65, get herd immunity there, that could do a lot to open things up. How does that affect?
Yes, this is the optimal strategy for vaccination is complicated. Most people, for political and sometimes for practical reasons, start with the most vulnerable, in this case, in this pathogen, which is the elderly. Certainly that's what Israel is doing, for example. But it turns out it's not so simple. There might be a strategy in which you actually want to vaccinate working age people, because what happens is the virus spreads through people who are socially interacting, and the elderly are at the end of the transmission chain. So if I vaccinate one young person, I might stop 5 elderly people from getting infected and prevent 2 deaths. Or I could use that same dose of vaccine on one elderly person. This is called network vaccination, actually. It's discussed a little in the book, but so it's not so obvious. Nevertheless, it's unlikely we would adopt that strategy. In fact, we've not adopted that strategy. We're starting with the elderly, which makes sense. You're right to highlight the fact that the mortality is very dependent upon age. And if you're younger than 25, if you get infected, you have a 1 in 3,000 to 1 in 10,000 chance of dying. If you're at our age approximately, you've got a 1 out of 100 chance of dying, which is nasty. Your risk of dying if you're hospitalized with coronavirus at our age is higher than if we had a heart attack. So if you're worried about dying from a heart attack when you're hospitalized, you should absolutely be worried about getting coronavirus, let alone when you get up to be 75 or 80, by which time you face a risk of death of 1 out of 5 if you're infected. So it's serious. But for any younger listeners right now, I also want to emphasize something else, which is that death is a problem of the aged all the time. So young people are unlikely to die of any cause in the next year. If you're 20, your risk of death in the next year is very, very small. But if you get sick with coronavirus, your death might go up 30%, your risk of death. So although as a parent, I'm very happy that if my young children were to be infected, I don't have to be so worried that they'll die. Actually, I don't have to be so worried they'll die of anything. And if they get infected, they're much more likely to die than they otherwise would have been. So I think the public health messaging about this has been a bit off. Nobody should be indifferent to getting infected with this pathogen. It just is an additive risk to anything else that we previously faced. All the risks of death we had before, starting in November of 2019, everything got worse. We're all at a greater risk of dying. It's bad. Something bad has happened to our world.
Yes, something bad has happened. That is for sure. Let's go to Ishita, please.
Thank you, Dr. Christakis. I just had a question about, you mentioned the factor of like human agency early on in your talk, and also kind of the mishandling of the pandemic by the current administration. So kind of keeping that in mind, I was curious about your thoughts about the ability of the incoming administration to combat not only like the biological effects of this pandemic, but also a lot of, the socioeconomic and the mental health and all the other impacts that come with the coronavirus.
I mean, it's not going to be an easy challenge. It's going to be very difficult. And I think that, Larry Summers and David Cutler, both economists at Harvard, former colleagues of mine, had a paper over the summer, short paper that called this the $16 trillion virus. These are vast sums of money that from the moment the virus hit our shores, we took an $8 trillion hit to our economy, and the further $8 trillion in damages to our health, the death, the disability, the illness, the lost productivity, and so on. So this is a catastrophic impact that we've experienced. But therefore, given the scale of the problem, spending tens of billions of dollars on a number of initiatives is peanuts, even though it's a large sum of money, but could be extremely helpful. So vastly more easy to get testing clearly needs to be a priority. Vastly improved surveillance systems so that we know where is the virus, how many Americans have been infected, is a new variant emerging. Systems that track. Here's another thing we don't know. We don't know if variants of the virus are more likely to make you sick or not, how sick different variants are more likely to make you, because we would need to couple variant surveillance with health outcomes. So we know, okay, these 1,000 people got seriously ill. Here are the variants they had. These 1,000 people got mildly ill. Oh, they had different variants. This would be a clue that certain variants are actually making you better or worse. We need that kind of data infrastructure. We need better public health messaging with trusted people. I'm thinking like Tom Hanks and Dolly Parton, not just politicians, that are actually out there talking about vaccination. So we need more testing, more surveillance, a better public health messaging. What I would have done from the beginning with this thing is I would have called the American people to sacrifice and shared burden. I would have said, this bad thing has happened. Our nation must prepare. We need to work together to combat this enemy. We need to be mature. We can't be like children and imagine that the problem is not there or that'll somehow go away. We need to actually face what's happening. And different sectors of our society will make different sacrifices. Many people will lose their jobs. Other people, like healthcare workers, will lose their lives. Rich people will have to pay more taxes. Some people, will run greater risks of infection. This is what happens during a time of plague. And so we have to band together to work effectively. And I think a framing like that by the Biden administration could be very helpful, sort of framing it as like a challenge to America and how are Americans going to respond? Anyway, those are partial answers, pragmatic and kind of framing things that the administration could do.
Thank you.
Okay, thank you. We are going to try, in classic World Boston fashion, to bend the rules of time and fit in one more quick question from Josh, and then we'll close out.
Thank you, Mary. I have a very specific question about long haulers, excuse me. So what is the science telling you about long haulers? I know some people who have suffered from, pneumonia and other diseases, but can these people recuperate quicker now that a vaccine for COVID has been discovered? What has the science been telling you about that?
No, I don't think if you are a long hauler, I don't think if you're a long hauler, giving you a vaccine will enhance or shorten your course. Now, there is immunotherapy for certain kinds of conditions. I have to think about this for a moment. I've not seen any literature on this, and I can't immediately think of a physiological reason, but there might be. I'm not 100% sure. So if you're 6 months into an annoying course of COVID, or 2 months in, does giving you the vaccine help? Typically what's happening for many of those people is that it's their own immune response that's causing the trouble. They've cleared the virus, but they are having some sequelae, some organ damage that's causing them trouble, some ongoing immune response. So I don't think the vaccine will help them in most cases. However, a rollout of the vaccine will prevent people from getting sick to begin with, which will of course reduce the prevalence of long hauling. I'd like, before you say goodbye to me, to just abruptly just read you, because I didn't talk about this, but it fits with my personality and my worldview, and also with the last book I wrote, which was called Blueprint: The Evolutionary Origins of a Good Society, which is generally that I think very highly of our species, and I think highly of human beings, and I'm optimistic about us and our prospects. And I just want to close then with a quote that's in the book from Albert Camus, who wrote this famous book called The Plague, which had a fictional protagonist called Dr. Rieu, who was observing an outbreak of the plague in Europe in the story. And Camus' book says the following: Dr. Rieu resolved to compile this chronicle so that some memorial of the injustice and outrage done them might endure, and to state quite simply what we learn in time of pestilence, that there are more things to admire in men than to despise. And that's honestly how I think about us and how I think we're going to see the other side of this.
Well, that is a great way to wrap this up and start the year. Thank you very much, Dr. Christakis, and thank you all for being with us tonight. Bye-bye.
Bye-bye.